Hi, my name is Tiziano Barbui. I am professor of hematology, Ospedale Papa Giovanni in Bergamo, Italy. I'm very happy to report to you about the abstract presented at the European Hematology Association meeting a few weeks ago, and which refer to some aspects related to the post-COVID in MPN, in myeloproliferative neoplasm. This is an European study by the European group dedicated to COVID-19 description during the first wave of the infection. We started in February last year, in 2020, to describe the first patients in Europe coming from many centers, from UK, France, Germany, Italy, Spain, and Poland. And we collected 180 patients with MPN and COVID disease. We published and the description of what happened during the first wave, as I said. And we registered patients with ET, PMF, and polycythemia vera. And we saw that the most vulnerable in terms of survival were patients with primary myelofibrosis. Overall, the mortality was found in about 30% of patients, but the mortality was higher in myelofibrosis, reaching 50% of these patients. This was published and we had also the opportunity to assess whether there were some risk factors to explain the mortality. And in addition to the severity of the disease, the intensive care unit admission of these patients, we found that the discontinuation of some drugs directed to control the MPN disease, such as ruxolitinib, was detrimental in terms of mortality, in terms of increase of mortality, especially in the first days after the admission. So the message was don't stop ruxolitinib when patients have the COVID infection. The second message from this first description was the thrombosis rate. The thrombosis rate was about 80%. And what we found is that it was particularly elevated in patients with essential thrombocytosis, essential thrombocythemia. And there are many explanations for this pattern of occurrence of thrombosis. And I have to say that the type of thrombosis was particularly elevated for deep vein thrombosis and pulmonary embolism. And we were able also to demonstrate that many of these thrombosis occurred in situ in the lung. However, we continue the observation of these patients. And today, I'm going to present to you what happened in the survival patients after the COVID acute infection. Unfortunately, only 125 patients survived after the acute phase of infection. So we described a long-term follow-up study in a follow-up study of these patients after 6 months post-infection. And we were able to show that 32% of these patients presented persistent symptoms after COVID. And fatigue was the most important symptom presented after dyspnea associated with sometimes with persistence radiological features of pneumonitis. Cough was another symptom in very important. But MPN major outcomes were thrombosis-free survival and evolution-free survival. Thrombosis-free survival was observed in some patients, exactly in 5 patients who determined thrombosis was ascertained intestinal ischemia, splenic infarction, deep vein thrombosis, acute myocardial infarction, and peripheral arterial thrombosis. Notice that only one of these patients, the patient who got peripheral arterial thrombosis, was treated, only one, with low molecular weight heparin after discharge from the hospital. So that 82% of these surviving patients were projected to be thrombosis-free after 6 months after the COVID acute phase, having a rate of thrombosis of 2.3% per year. So thrombosis is still elevated after the recovered patient, in a recovered patient after COVID acute infection. And also we observe evolution of this disease. We described 3 patients who developed acute myelogenous leukemia in this period. And acute myelogenous leukemia was described in patients with myelofibrosis, essential thrombocythemia, and prefibrotic myelofibrosis. These patients were treated with hydroxyurea. And I have to underline that 3 patients were in the chronic phase before the infection. And another evolution was seen in terms of lymphoma, non-Hodgkin lymphoma in one case, and the progression of parotid carcinoma in the last patients. All these patients were on treatment with hydroxyurea, and only one with ruxolitinib. So that the overall survival was seen in 90% of these patients. It means that 10% of these patients died after the acute phase and in the first 6 months after discharge from the hospital. So the overall mortality, you have to add this 10% to the 30–40% observed during the acute phase of the infection. And the causes of death were acute myelogenous leukemia, progression of solid cancer, and multi-organ failure, thrombosis, heart failure, and in one patient, it was unknown. If you make a sum of all these events, so thrombosis, evolution, you have an event-free survival probability that is about in 60% of these patients, meaning that 40% in post-COVID of this patient can experience one of these events. And the rate is 7% patient per year. So I would like to make a comment regarding these features I presented. This is a multi-center European study. Although with a relatively small number of patients, it provides a descriptive picture of MPN patients who survived after COVID-19. There is a diversity of complications that further increase mortality and morbidity of MPN patients in this period. Indeed, 40%, as I said, of these patients followed over a period of 6 months after the acute illness subsided, experienced both fatal and non-fatal events. This research indicates that the health consequences of COVID-19 extend far beyond acute infection and suggest a larger multi-center analysis to increase and expand our observations. These are a signal that should induce careful surveillance in all patients with MPN, regardless of the severity of acute infection of these patients. Thank you for your attention.